I'm a medical sociologist and a sociologist by background. Most of my research is about stress and health, especially the impact of work stress on biophysiological functioning and cardiovascular functioning. So I was very delighted to be part of a group that was not looking at how stress impacts on your health, but more about what can we do to improve stress in the workplace. So I was invited by my colleagues in Queen Mary, University of London, particularly Stephen Stansfeld, who some of you may know is a consultant psychiatrist. Cam Bui is also a consultant psychiatrist, so they're very much part of this, the professions represented here. First of all, why are we interested in this topic? Well, I probably don't need to convince you. You've already heard from this morning's speakers about the importance of well-being and well-being at work in particular. We know from a number of reviews that the stress at work, the psychosocial work environment, has a very large impact on employees' well-being. We know it through measures of well-being, mental health, sickness, absence. I list some of the reviews that have been done over there. At the end, I have a full reference list for those of you who are interested in that. A slightly older reference about the economic impact of mental ill health at work from the Sainsbury Centre review in 2007. Which said that there's a huge cost to UK employers for absenteeism, presenteeism, and staff turnover. And we know that that cost has increased, partly because of the last point in that slide, which is because that 40% of sickness absence is due to mental health problems. And my colleagues in Manchester have updated this cost in terms of sickness absence. All of you know that may know that the number one cause of sickness absence in the workplace is actually not mental ill health, but musculoskeletal disease. So that's through an analysis of fit notes that have been issued. So the fit notes came in about 2 years ago. My colleagues in Manchester has access to those to an analysis on the fit notes, and clearly musculoskeletal disease, musculoskeletal problems are the number one cause of sickness absence. But when you look at the number, and the second cause is mental ill health. But when you look at the number of days taken off due to ill health, then mental ill health is the number one strongest component of the number of days. So in terms of productivity lost, mental ill health has a far more important role in causing sickness absence than musculoskeletal problems. So clearly it's a very big issue, not just for the employees, but also for organizations, for businesses. There have been a lot of intervention studies on stress in the workplace. Most of them target the individual. A few of them have targeted the organization. So at the individual level, there have been interventions to target relaxation, meditation, CBT, treatment with medications. Some have been slightly more successful than others. The relaxation therapies or the CBT procedures have had more positive outcomes in terms of reducing stress levels. In terms of health promotion, there's been a more mixed message. Overall, I think exercise tends to be a good thing. I mean, it's a good thing for lots of different outcomes, but health promotion in of itself, in generally, doesn't seem to reduce much sickness absence. In terms of the organizational interventions, there have been at least 3 major reviews of these organizational interventions, which show very mixed outcomes. Whether or not these organizational interventions to try and reduce stress in the workplace has impacted on mental health outcomes, that's something that hasn't quite been. The evidence isn't particularly strong for that. And a meta-analysis of about 48 studies of occupational stress interventions showed that the vast majority were targeted at the individual level, so at the employee level, rather than trying to do something at the organizational level. Here are a few of those reviews that I mentioned in the previous slide. The first one at the top there, Egan, reported that there have been some successful interventions that have actually improved stress in the workplace. They've decreased the job demands people felt. They've improved support at work. But whether or not this actually translates into better mental health outcomes, that bit is missing. So the second review there by Claire Bambra and her group shows that there have been interventions to increase the amount of skills, discretion in the group, the amount of team working and control at work, decision latitude, but they found very mixed results in terms of mental health improvement. The third review over there found that there have been successful interventions to increase participation and decision-making at work by the employees with increased work support and communication, and this did lead to reduced sickness absence. And the fourth review over there, that meta-analysis by Parks and Steelman, found that actually employees participating in organizational wellness programs that was associated with decreased absenteeism and increased job satisfaction. So some of the common methodological problems in a number of that these reviews have highlighted is that there's actually a scarcity of randomized control trials on these organizational-based interventions. So most of these previous studies don't adopt an RCT approach. There is an intervention, but the intervention is not randomized in the organization, and that brings about potential for bias because there's selection of the intervention and control units that might actually be impacting on the results. But it's very difficult to organize an RCT in a work context. Employers in general don't like them, in particular going into private organizations because they're afraid it might reflect badly on them. What if the study that you do actually shows that their employees are really stressed out, and that you haven't been able to make a difference. And methodologically, it's also really quite hard to do because we're trying to intervene at the organizational level, but we're trying to make a difference to the employees. So we're following up the employees, but intervening at a different level. And that makes it really quite hard to do this sort of cluster randomized control trial. Later on in the talk, when I talk about the specific study that we did, I'll talk about the particular problems about managers and trying to improve manager behavior, which then hopefully improves the stress of their employees that they manage. So there's actually not much knowledge about what works at an organizational level to improve employee well-being. In terms of measuring the stressful working environment, thankfully there are actually quite a few models and theories and concepts and questionnaires that have been developed over the years. There's the job controls, job demands, job strain model, the effort-reward imbalance model, and the health and safety executive management standards. I'm focusing here on the psychosocial or stressful working environment, not so much on the physical work environment, although that is also an important consideration. But this particular intervention was targeted at the psychosocial working environment, not improving the physical working environment of the employees. Some of you may be familiar with the job strain model, which is basically two dimensions. You try, employees either have a combination of low control at work, or they might have a very demanding job, high job demands. And it's this combination of having low control and high job demands that is particularly meant to be stressful. And there have been a number of reviews now which suggest that actually this combination of low job control, high job demand, is strongly associated with depression, anxiety, a whole range of mental ill health measures, as well as physical, physiological, and cardiovascular measures. The other model that was developed in the 1990s by Johannes Sigris is the effort-reward imbalance model. There's definitely overlap with the previous model, but that's basically a situation when an employee puts in too much effort into their work and gets very little reward out of it. So again, two dimensions, effort and reward, and the imbalance between the efforts put in and the rewards that people get out of it, that leads to stress. The management standards that the Health and Safety Executive proposed a few years back, largely follow these concepts, these theoretical models, but in particular place emphasis on the last three. What's new is the relationships, the roles that people have, that employees are clear about what roles they have, and change is another important dimension of the management standards that's not really reflected in the previous two theoretical models. And importantly, these management standards can be written up as desirable states for the organizations and have been explicitly written up as management competencies. So a manager is expected to be competent in all of these dimensions and can be assessed in terms of these dimensions. So the rationale for this particular study that I did with my colleagues is to whether we can intervene at the manager level. Can we make managers become better managers so that hopefully their employees' well-being will improve, so that they know what to do when their employees are stressed out. Now I'm going to digress a bit from the slides here because yesterday one of my colleagues that I manage came to me and he said, "Yeah, I've been, in reported stress at work. Basically, she had a lot on her plate, and she needs help. So my first reaction is to do the standard thing. I was like, okay, great. Let's report it up. Let's get occupational health involved. Let's get HR involved." And she said, no. She's been through that before, and it was a nightmare. She definitely didn't want to go down the occupation. She didn't want it to be on her record because then it has implications for her mortgage, for her insurance, for her relationships at work. She said no. And in a sense, I was glad that I didn't have to officially report it. I got consent from her not to officially report it. She wanted it to be dealt at a local level. She wanted me, her manager, to deal with her work stress level. So this was an example of not trying to push this problem of a stressed out employee onto occupational health services or onto HR, but trying to get managers to become more responsive to their needs of their employees. So could we train managers to become better managers? And the specific intervention that we came up with was an e-learning intervention that targeted these management competencies by the Health and Safety Executive. And hopefully this will improve the stress levels of the employees. It's potentially cost-effective because it's an e-learning intervention and convenient and accessible to many managers at once. So we applied to the National Institute of Health Research, the NIHR, with these following objectives. We wanted to evaluate a guided e-learning intervention. It's guided because there were 2 face-to-face workshops that the managers did alongside the e-learning intervention. So it was very much a blended distance learning intervention. It was using the management standards. It was directed at the managers, but we wanted to measure the outcomes among the employees. So we wanted to see whether, it was a pilot study, we wanted to see whether or not the program was feasible, whether it was acceptable, whether the intervention was successful, whether the managers complied or adhered to the e-learning intervention. And we piloted the data collection for both the well-being and sickness absence, and as well as the economic cost effectiveness of this intervention. We did use the Warwick Edinburgh the WebWEM scale as the primary outcome, but we did use other outcomes as well. The general health questionnaire, I think Peter showed some analysis from the Goldberg, so I think that's pretty much the same as this GHQ psychological distress questionnaire. We measured sickness absence, both self-reported as well as collected by the organization. And of course, we measured the stressful working conditions. And as it was a pilot study, the focus was very much on testing the feasibility of the data collection and the acceptability of the intervention. So this is a study design. The managers have some levels of competency to deal with stressed out workers. That's prior to the intervention, so they have these baseline competencies on dealing with stressed out employees. The employees have their well-being before the intervention. The managers then get the intervention. Hopefully, the managers change their behaviors and they have their competencies to deal with stress at work improves, and that in turn improves the employees' well-being. That was what we were hoping for. And that's how we measured, that's what the study actually measured. The well-being questionnaire was administered before the intervention, which was the e-learning program, and then we repeated the well-being questionnaire afterwards. The actual e-learning program was developed around the health and safety executive model, and it had 6 modules. The first 3 modules was about why stress at work is important to tackle, and then modules 4, 5, and 6 was very much about what can the manager do to improve stress at work. And then there were 2 facilitated workshop sessions with phone and email support for the managers. Overall, it took on average the managers 2 hours to complete this e-learning program, although they tended to do it at separate sessions, between 3 to 6 sessions to complete it. So it wasn't very long in terms of time commitment, but there were still problems for the managers that I'll come on to. So the groups of the employees these clusters were randomized for their managers to either receive the intervention or not. We actually did the intervention in a mental health trust, and some of you may know that those are not particularly easy organizations to work with. The mental health trust was actually fantastic to work with, but a lot of employees there tend to face very stressful working conditions. So we did this in the Northwest, and we had 3 adult mental health units and 1 learning disabilities unit. These 4 clusters, which were then randomized, and the way how the randomization worked out was that the mental health, adult mental health groups were in the intervention group, and the learning disabilities was in the control group. That's a pity, because it would have been good to have a mix, learning disabilities in with the intervention group, but that's the way the randomization worked out. The study timeline was that we recruited the employees in around the summer months. The manager e-learning was between October and December, and the sickness absence in the repeat questionnaire was measured in January to March. Again, those of you working in the NHS knows that's the worst possible time to measure anything, to do any research in the NHS. And it won't come as a surprise to you that on average, both across the control and intervention groups, well-being actually fell. And I think that there's a strong seasonal effect going on here. We measured well-being initially in the summer, and then followed up in the winter. So the results, well, in terms of recruitment, there was a positive story there. We had a target of 100 per cluster, and pretty much fulfilled that for all of the clusters except the learning disabilities group. In terms of recruiting managers, we hit our targets as well for the 3 intervention sites. In terms of the employees filling in the questionnaires, we hit our targets of at least 80%. Finishing the baseline questionnaire, and out of those, at least more than 80% filled in the follow-up questionnaire. So all of that was good. We collected the sickness absence on over 90% of the employees, so that was also good. So in terms of the acceptability of the questionnaire, and also in terms of the e-learning program that I'll come on to, we found quite a high degree of acceptance in the trial. Where the trial failed quite badly is in terms of manager engagement. So we had quite a very loose criteria of adherence or compliance with the intervention, which was the managers had to complete at least 3 out of the 6 e-learning modules. Yeah, so half of the e-learning modules, and we didn't hit that target. Only 51% of the managers finished 3 to 6 modules. So about half of them didn't even complete 3 modules, so half the modules, and 12% withdrew. Now, withdrawal could be due to a huge number of reasons. One being managers leave the NHS. People leave the NHS all the time. But because of intention to treat analysis, the standard way of analyzing randomized control trials, we have to treat these managers as though they were still in the workforce. Managers were assigned to different units, yeah? So the managers are no longer managing the employees that they were recruited into. But again, according to by ITT analysis, we have to treat those managers as though they were randomized into the groups they were originally randomized into. So there are a lot of reasons why manager engagement was pretty poor. In terms of the employee well-being, these are the standard questionnaires that are issued in terms of work at Edinburgh. And as I mentioned, there was basically not much effect, not much difference between the intervention and control groups. This is in terms of the WebWM scores. So for the interventions on the left-hand side, the intervention group, the Warwick Edinburgh average WebWMs was 51, and that fell. So well-being decreased to 49.9. It was a slightly smaller decrease than in the control group, where the well-being dropped slightly more. So when we actually do the intervention effect analysis, we find that there was a small positive increase in the well-being score, 0.5, but it was not statistically significant at all. And this is about, when we looked at adherent managers, when we just looked at managers who complied with intervention and compared them to managers who did not comply with intervention, we did find that there was a significant improvement in the Warwick Edinburgh score of 1.6. It's not very big. We were hoping for 3, an improvement of 3. That's what we were statistically powered to do, but it was a significant improvement. For those of you who are eagle-eyed with statistics, you'll see that the baseline well-being score of the adherent managers was 52, was actually higher compared to the baseline well-being scores of the non-adherent managers, which is 49.8. So I'm not saying this is a causal effect, because of course the reasons why a manager could be adherent could be something to do with the manager themselves. It's not, this apparent improvement in well-being could be not due to the intervention, but some other skills that the manager already has prior to the intervention. In terms of sickness absence, again, you'll see there's not much difference between the intervention and control groups. In terms of psychological distress, it's actually going the other way. The intervention, the mean GHQ-12 of the interventions group increased from 2.8 to 2.9, while in the control group, their distress scores decreased from 3.2 to 2.9. In terms of supervisor relationships and support at work, there's basically not much change between the intervention and control groups. In terms of effort-reward imbalance, we do see a small decline in the levels of effort-reward imbalance. You can see for the intervention group that dropped from 1.37 to 1.21. There was a smaller drop for the control group from 1.07 to 1.01. And when we actually do the statistical tests for intervention effects, I'm looking at the adherent versus the non-adherent managers, and we see that there was a decrease in job strain for the adherent managers of negative 4.6. That's borderline statistically significant. And for effort-reward imbalance, we also see that the adherent managers, the odds of their employees reporting effort-reward imbalance dropped from 1 to 0.6, and that's, again, borderline statistically significant. We did cost effectiveness and cost benefit analysis. The actual cost of the intervention was about £623 per manager and £75 per employee. From the employer's manager, the intervention did not have a positive impact on the cost-benefit balance. That was largely because we did not find a significant improvement in the well-being of the employees. In terms of the qualitative results that we did, we interviewed a lot of employees and managers, as well as key managers in the health trust. And we found that in terms of the acceptability of the e-learning intervention, we were interested in finding out why the managers wanted to do this study. And some managers had a particular interest in stress. They wanted to help their team to become better managers. They had positive attitudes to e-learning, and they actually found that the e-learning program was easy to access, simple to use, visually appealing. It was superior to their standard e-learning packages that they used in that NHS trust. They found the materials were useful, and the modules were not too time-consuming. Their opinion was that they weren't learning anything new, that this reaffirmed their existing knowledge about how to deal with stressed out employees. The content was familiar, but they did say it was good to have their existing knowledge reaffirmed and practice reaffirmed, so that was reassuring. And it was particularly important for managers who had never received any training to deal with stress at work. And I think, so although the modules were not time-consuming, a lot of the managers found it really difficult to find time within their working day. There was no separate time allocated by the senior management, so that meant that the managers had to carve out some time, and it's not easy. For those of you, again, who work in NHS Trust, it's not easy to find protected time to do extra learning. It was easier for some to find protected time and space than others, and a lot of managers were prone to interruptions because they were based in an open office. So I'm coming to the discussion part. And so what are the factors that could have affected the trial outcomes? Maybe the interval between the intervention and follow-up period was too short. We only had a 3-month interval between the baseline and follow-up. The intervention itself could be strengthened. It was an e-learning program with a little bit of face-to-face workshops. So maybe the intervention itself was not great. There was a lot of organizational change going on. As I said, a number of managers left the trust or were reassigned to different units. And it's possible that maybe stress at work is not the #1 cause for well-being. We know from a lot of research, stress at work is important, but it's not as important as financial stress, as stress from family relationships. So we had poor uptake from the managers that we wanted. And it may be that the managers and teams who could have been helped the most by the intervention didn't engage with it. So we had, as I said, around 50% of managers were not compliant. And those non-compliant managers actually had lower well-being scores for their employees prior to the intervention. The managers found that they could not set aside time to complete this intervention that might have been due to organizational changes in the trust. So in the future, we might need more explicit buy-in from senior management to ensure that this intervention is accepted as everyday practice. So overall, we thought that the trial was acceptable to the managers and employees, and the recruitment of the employees was good. The data collection targets were met. The negative was it didn't make a difference. There was no significant improvement in well-being, and that the manager engagement intervention was not good. So I've repeated these slides here. We do have plans for not the full trial, but now we're going to submit another pilot study where we're planning to work on this intervention to make it more engaging and appealing for the managers. We want to include some self-assessment of the manager's skills and more face-to-face discussion with their peers. We will try to get greater engagement with senior management and to increase the interval between the intervention and follow-up period. And we'll try to go in the private sector as well as the public sector organization. So with many thanks to the funders, to the research team at the Health Trust, and the occupational health team there, to the GEM study team. GEM stands for Guided E-Learning for Managers, largely based at Queen Mary University. Here are some of the web links for the GEM study, the papers that have been published, and references that I've cited in the presentation. Thank you.